So I would like to thank the organisers for asking me today to talk about some of the changes that are happening within the maternal immunisation schedule, and also what have we learnt about the vaccines that we have had in that schedule. I'd first like to acknowledge the traditional owners of the land that we're on, and their elders past, present and emerging, and any Aboriginal people who might be online or in the room with us today. These are my conflicts of interest. I've worked with a lot of different companies as part of clinical trials and providing advice around vaccines, and I was also sat on a number of committees, but I'm giving you my personal opinion of how I see the data, and certainly don't take to represent anyone particular. So in 15 minutes, I just really want to reiterate a point I raised at the CDIC meeting. We're talking about COVID vaccination in pregnancy, because I think it is something that sort of perhaps we could be a bit more proactive about. I'll update people on where we're at with maternal vaccination for RSV and the latest data that we have from the one licensed vaccine that is now licensed in Australia and should be available on the private market in the near future. And talk a little bit about where we're going with maternal vaccines in the future, but I'll try and keep to time. And I think it's important to acknowledge that we've had flu vaccine on the National Immunisation Program for almost 15 years now, but we have really struggled with coverage. And when Michelle Giles put up the data that they were getting around maternal coverage in Victoria, I went, "That's not true." I said something maybe a bit not quite as delicate as that, but and I actually spoke to her because I thought there must be some data issue. You know, over 80% in maternal immunisation. That's just, you can't get that. That's not happening. But actually, she went through it, and I think there was a number of things that went, and it was really about this access point that we heard earlier. It was really about making sure that people knew what their coverage was like. So there's a public dashboard. Hospitals are accountable for it, and it's one of their KPIs, and that's been one of the successes in Australia to get to that 95%, is actually having a immunisation coverage on everyone's KPI. And then the other one is actually working out how you can deliver it in a maternity hospital, and they could deliver pertussis vaccine but not flu because that wasn't in the fridge. They only had pertussis vaccines in the fridge. So clearly some of those, and you have to have a solution at an individual level for each hospital or each group of patients or each district or each state, I guess. So that was really something I learned about maternal immunisation. We're almost up to 10 years of experience with pertussis immunisation that has been highly effective, preventing young babies being in hospital. We are now starting to see some more babies appearing in hospital, unfortunately, but I would just like to acknowledge Kath Hughes and the fantastic work that the Immunisation Foundation of Australia did in raising awareness and really getting the states to roll out the programs, and eventually the Commonwealth came on board with the NIP. But I was a little bit concerned about some evidence that when you get very high levels of antibodies in young babies receiving their first vaccines because of maternal vaccination, that can sort of somewhat diminish their responses, although not below protective levels, we didn't think. And it was thought to relate to the tetanus toxoid component. So, and the good thing was when we looked at children born to mothers who'd had 2 or more vaccinations, that didn't seem to be any different. So that's useful to know. But I think we now know there is emerging pertussis. It's a East Coast, New South Wales, Queensland problem. So we're in the middle of the pertussis epidemic here. So all those people that are coughing around the room, please go and get a pertussis swab as well as your COVID and flu. And it's really kicked off just since late 2023. So, and you can see the numbers there. This is from a couple of days ago, so it's probably over 9,000 now, judging by the amount of people who are coughing in the conference. But actually, it's mostly school-age children, so 5 to 14-year-olds. So there are a significant number. You know, almost 9% are under 4, and some of those are little babies ending up in hospital because coverage of maternal pertussis has dropped a little. So I think this is really important, and I guess one of the questions is, could this relate to, you know, an impact from having had maternal immunisation? Because those primary school age children are actually in the window of where they would have had a reasonable chance of receiving it, somewhere between 60 and 80%. So we do need to know that there is a pertussis vaccine that hopefully will be licensed in Australia, that it's only for pertussis, so it doesn't have the diphtheria and importantly the tetanus component of that. And we do know that our current vaccines do have waning immunity after sort of a period of 12 to 24 months. And there is some evidence that actually having a different way of detoxifying your pertussis is important. This vaccine is called Pertigen, is licensed in Thailand and Singapore, and is actually being provided to the Thai women whilst they're pregnant as part of their national program for free, which is good. And we've been involved in a study that was funded by Technovalia, who's the Australian offshoot of the company that makes the vaccine, thinking about, would this be something that we could look at for pertussis vaccines in Australia? And so we recruited just over 100 young adults, and they were randomised 2-to-1 to receive the Pertigen vaccine or Boostrix. And you can see here that when you're looking at the pertussis antibody level, which is important when we think about maternal immunisation, because that's really the things that stop the babies getting sick, you can see that it was higher both 1 month after they had those vaccinations, having had similar baseline levels, but also was still higher at a year out. So this might be a vaccine that may give us better protection without having some of those impacts on the infant immunisations. But I think that needs to be proved as well. So I think there is some more research to be done. But I think it's going to be interesting, and that may change the landscape and might help us improve protection, as there is some evidence that there's waning immunity after that third dose of infant vaccines when your mother's been vaccinated. So quickly switching to COVID. So we just had a discussion about how complex COVID is, and the information is changing all the time. And we did have a recommendation to vaccinate pregnant women, but we now don't. And I just wanted to say, should we rethink that? This is the recommendation compared to flu and DTP, not routinely recommended in pregnancy, but can be considered. So that's really saying if the mother demands it, then you can give it, but actually otherwise don't bother. Probably not worth the discussion would be my interpretation of that recommendation. The US have something called shared decision making, which is much more about having a proper conversation, I think. I think this is really saying can be considered. It's not really shared decision making. But actually, and Hazel pointed to some of this issues about, we do know that complications of COVID are certainly an impact for the fetus as well as for the infant. And this is just a recent publication that I pulled out from a couple of months ago that shows that Omicron, although it's not as bad as in terms of eliciting complications as Delta, there's significant increased risk of all these fairly rare but very traumatic pregnancy complications on the right. You can see there thromboembolic disease, death, ICU admission, but actually it's the ones on the left I think are more of an impact on our general population. So the increased risk of preterm delivery and stillbirth, I think, is something that any pregnant woman would want to know about. And so we need to think, should we have that conversation? And I think the other reason why this is important is the vaccines that the adults have were the original Wuhan strain by and large, unless they've had a recent booster. And we know that that vaccine doesn't provide any neutralising antibody, even though you do get in terms of the newer strains that are now circulating. So it still protects very well against Wuhan, if that's what we were dealing with, and probably Delta, but not so much the new JN1 strain or even the subsequent ones that we're seeing. So whereas the XBB booster that's now available actually does generate neutralising antibodies against those newer strains. So I think the landscape has changed. And and this was a very large study, as you can see, and a large number of COVID cases. And this is Australian data. So this is from the PEDS network that's run through the National Centre. And again, this was the number of admissions that have occurred since COVID started in children. And a third of them are actually in children under 6 months. Almost half of them are in children under 6 months of age. Generally, most children don't stay very long, but a significant proportion do. And you can see there that the 1 in 20 are getting admitted to ICU. So this is still an ongoing issue. So we've had about 600 admissions in the last 12 months. So whilst the time when Omicron's circulating. So I think, and that may go up as we get more waning immunity from previous vaccinations. We have a lot of good evidence from the United States particularly, but also here in Australia when we were using this vaccine that it's safe. And there's some recent data that's published that I won't go through today that shows high levels of preventing the mums getting sick enough to seek urgent care, but also the babies being hospitalised at 3 months as 56% and 34% at 6 months of age. But I can understand there are some worries about will this interfere with our other maternal vaccinations. But this was my suggestion. I think we could have a more permissive recommendation that have a discussion with the parents. If they want to reduce the risk, then provide the vaccine as a booster. And I think that's something that should be considered. So hopefully ATAGI will perhaps re-look at this sort of with the updated data such as that I've just showed you. And so for the last sort of 5 minutes or so, I just really wanted to talk about the RSV vaccines, which we were talking about taking a long time to develop them. Well, this is a vaccine that's been 60 years in the making. So, and I won't go through why the original vaccines didn't work and actually made children get sicker from the vaccine, so that vaccine adverse event. But importantly, 10 years ago, we actually worked out why the previous vaccines didn't work. And that was all about the structure of this fusion protein that's the RSV equivalent of spike. And understanding that structure and how to stabilise it actually meant that we now have been able to develop highly effective vaccines, as well as actually doing the same for COVID. So using that exact same technology to develop the spike-based vaccines that were so successful. So I think really the work done in RSV also should be considered in that how long has that we taken to develop a COVID vaccine. Actually, it was all this previous work we were doing in this space. And just to remind everyone who's not a paediatrician, I think most GPs will know this, that RSV is the most common cause of children getting hospitalised. It's more common if you're Aboriginal, and it's mostly in the first 6 months, particularly in the first 3 months of life, although the increased risk does go up to 5 years. Prematurity, other medical problems, you mean you're more likely to get hospitalised, but actually most children getting hospitalised, 83% of them don't have any other health problems. So this is a disease for normal infants. The other thing is there is a distinct seasonality. So if you're born, you can see in that figure at the bottom, whether or not you're premature or a term baby, which are the different sort of lines you can see there. If you're born in September and October, you're sweet. Your chance of getting hospitalised is very low because you will already be over 6 months of age before RSV starts circulating. But I think it's clearly if you're born in the first half of the year, it's a much higher incidence, and that's important when we're thinking about things like when to vaccinate somebody and where do we get the most benefit from providing a vaccination on somebody according to their age when they're in the RSV season. And not only that, if you're unlucky enough to end up in hospital with RSV, you better get used to it because you will be much more likely to represent with wheezing illnesses or chest infections over the next few years. 1 in 10 of those babies that are admitted, and that's quite clear, and maybe also contributes to long-term asthma as an older child and young adult. So this is something we'd like to prevent. How can we prevent it? Oops, sorry, I don't know. Hang on a tick. Yep, okay. Well, actually, we want to raise maternal antibody levels. So in grey, you can see that we can raise the maternal antibody levels by vaccinating, and they remain above a protective titer that we know from our current monoclonal antibodies that last till 6 months. And so this has been evaluated in a recently published vaccine. It was found to be safe with no difference in the pregnancy outcomes, but high levels of efficacy against severe RSV disease over that first 6 months with over 70% protection. Similar, slightly lower against hospitalisation because some young babies get admitted, but also prevents you having to see the doctor, which is generally about 1 in 10 children at all. And there's been more than 1 million doses have been used in the US and Europe, and was recently registered by the TGA. But there's a few questions that I won't have time to go through, but I think it's important that it doesn't interfere with other vaccines, so you can concomitantly administer it. But the key question is cost effectiveness, and that's something that comparing it to things like a monoclonal antibody, and there are some advantages of maternal vaccine, but there are some advantages of monoclonal antibody, particularly its flexibility and the demonstrated uptake and efficacy in Europe, and we will soon see that from WA and Queensland. So just to finally say, I think the maternal immunisation is great. As a paediatrician, it protects the most vulnerable babies that we haven't been able to protect with immunisation that starts at 6 weeks. We need to understand how interactions between vaccines we give to mums and babies, but particularly for pertussis. I think we could do better around COVID vaccines. There's new vaccines coming down the line that would be appropriate, CMV, Group B strep. But if we have too many vaccines, can we fit it in? You're pregnant for 9 months. I think we should be able to find some sort of schedule that would fit in that period of time. And maybe we'll have some combined vaccines that'll be developed for older adults, but also might be able to use for mums. And I would just like to acknowledge all the people who have done the hard work that I've presented today. So thank you.
An excellent talk. They can turn this on, or they can. We've got time for 2 or 3 questions. I also was astonished about Michelle Giles. I mean, it has to be done obviously at a hospital basis. Last time we looked at this when I was in Queensland, 85% pertussis coverage, 35% flu coverage in pregnancy, and I'm not really... Well, I know why. I mean, the factor was it wasn't being recommended by theirs. And so I'm intrigued as to whether you've got suggestions as to how we get someone to decide that they need COVID, flu and pertussis when they see these pregnant women, because we're not winning on the other 2 at the moment.
Yeah, I mean, I think we've heard some of the ways that we can do it, you know, having those discussions in an informed manner in a way that suits the mothers and families that you're talking to. I think we need to have better ways of providing that information at our fingertips. And I think, you know, having apps where we can do some of these calculators that are very easy for people to use. But I think the first thing I would do is just make sure that everyone has both those vaccines in the fridge, and that if you're in a maternity hospital, you can get a flu vaccine or a COVID vaccine in the clinic. And I think because I think we have to remember that if somebody is coming to a hospital for an outpatient service, they're probably less likely to be going to their GP. You know, if we say at the hospital, well, actually, why don't you go and see your GP and get a vaccine? And they'll go, oh, really? Can you not just give it for me today? I think we've got to make it simpler. And what Michelle gave a couple of examples when I spoke to her afterwards of exactly where there was pertussis vaccine in the maternity hospital fridge, but no flu vaccine. That's just crazy. You know, and then as soon as they introduced it, they were able to increase their rate in that particular hospital. So the accessibility is probably the easiest stuff to fix, I think. I think that the attitudes is a little bit more complicated, but protecting your baby is pretty important when you're pregnant. So I think we just need to reinforce that. But I'm happy to take advice on that if I'm getting that wrong.
So quick question before I hand it to Robert.
Yeah.
We now have the availability of a monoclonal antibody and we have availability of a maternal vaccine. Will the recommendation be seasonally based or preferentially based, or how are we going to deal with that? These 2 processes are probably both very good, but different.
Yeah, no, look, I think that's really interesting. And I think we're seeing that recommendations are being implemented differently for both those particular applications. So whether it's a maternal vaccine or a monoclonal antibody. I mean, if you're going to be giving both of them year round, then probably there's very little difference, to be honest, because you're getting similar protection. If you're having a seasonal campaign, which in WA, I showed you the data, there's no point us vaccinating somebody who's going to be born on the 1st of October if we're trying to prevent hospitalisations, because the benefit of that, it will probably have worn off. Now, that's not necessarily confirmed because there was some issues with RSV circulation in those efficacy studies, and maybe you get longer protection from maternal vaccination than 6 months. But I think it's going to come down to how much these interventions are going to cost. I think that's the biggest issue, and that will be important, and it'll be the PBAC who'll be making those calls, I think. But I think in the meantime, and you know, we can't call a monoclonal antibody a vaccination, but we could have it in our national immunisation program. So I'm just hoping that we actually get somebody doing that piece of work, because that's critical to getting good coverage.
Peter, your work with monovalent pertussis vaccine in pregnancy is important and very interesting. Producing more antibody in the mother leads to more antibody going to the baby. So why is that not an issue in terms of dampening down the baby's response to the 2-month vaccine.
Yeah, I think thanks, Robert. It can be. So it may be that actually if getting your pertussis antibody too high pertussis toxin too high might not be a great idea for when you're over 10, 12 months, maybe you will be more at risk. But if you're getting better protection in that first 6 months, that's more important. And we think that you probably don't need a tetanus vaccine every pregnancy, and that might make things a little worse. Sorry.
It's mostly just a comment. I've heard lots of people raise this concern about how many vaccines we're going to get into pregnant women. But in my experience in the field, and also just being at this conference and talking to my family members that are pregnant, all of them are so excited to get an RSV vaccine. Like we've heard stories about kids that have RSV. And so I think if you are lucky enough to have come across healthcare workers that are passionate and informed and recommend the vaccine to you, mothers are not hesitant to get these vaccines.
Yeah, that's very true. And we've actually done some work on that, showing that there's more than 85% acceptance of a maternal RSV vaccine or a maternal antibody. In fact, mothers seem to be more inclined for a vaccine than an antibody. I think that's probably because they don't know really what you're talking about. If you call them, but in Spain, where they got over 90% coverage, they just said it's a bronchiolitis vaccine. So I think that's right. I think for GPs who are online or in the room, I think this is something you will notice, that you will see less of these small babies coming into your practice, getting otitis media, getting chest infections, getting bronchiolitis, getting sent to hospital. So the number needed to treat is pretty low. It's 1 in 25 to prevent a child being hospitalised with the monoclonal antibody, and that's probably not going to be too different with the vaccine. So I think this is a big shift, and I think it might be useful to use that to, if there was a maternal vaccination for RSV, you might find it actually boosts flu as well. And we need to talk about them in the same breath, I think.
Thank you. If we could just thank Peter for his excellent talk.